Hi there, is this Howie?
Hi, yes, it is.
Hey, my name's Dr. Cooper. I'm one of the pediatric residents.
Oh, nice to meet you.
So what brings you guys in today?
Well, Howie's not been feeling very good, and he just hasn't been himself. So for about 3 days since we've been back from camping, he's just been nauseous and throwing up, and he hasn't been able to keep anything down. He will drink a little bit, but not really eating, and he's just been complaining a lot of a headache.
Has he had any fevers?
He hasn't felt warm. I mean, I haven't really taken his temperature, but he doesn't feel warm to me at all.
Has he been able to take anything down to eat or drink?
We tried just like bland things. I tried some bananas, just some toast, and a bite here or there, but mostly throwing it up.
Okay. Is he having diarrhea as well?
No diarrhea.
Where were you guys camping at?
We were at Table Rock Lake.
Oh, okay.
Yeah.
Yeah? How long were you guys there for?
We were there for a week.
Okay, nice. Anyone else sick in the family?
No. Oh my goodness, Howie. Oh geez. Oh my goodness. He can't keep anything down.
Yeah, I see that. Poor guy. Does he have any health problems at all?
No, otherwise totally healthy. He's my healthy one.
Okay, all right. And no allergies?
Nope, no allergies. Immunizations are up to date.
Okay. Has he ever had surgery before?
He was like a year old, 18 months. He had ear tubes.
Okay,
And they took his adenoids out too, but that was it.
Okay. Has he complained of anything else, like pain or?
He's just not been himself. He's not been out playing. He hasn't really wanted to do much, just kind of laying around.
Okay.
And then he hasn't even really wanted to watch TV because he said his head's been hurting.
Okay. Has he been talking to you and interacting with you?
Yeah, he'll talk.
Yeah.
He's just been pretty tired, but he'll talk.
Okay. All right. Well, let's go ahead and take a look at him.
Okay, sounds
All right.
good.
I'll take a listen. Hi, Amy. I just got done looking over Howie here. I was hoping we could get him hooked up on the monitor and get some vitals.
Absolutely.
I'll get
Thanks.
vitals.
Hi,
Well-
Howie. My name's Amy. I'm going to be your nurse today, okay? We're just going to take a look at you and get some of these stickers on.
While you're looking him over, I'm just going to summarize a couple of the things that I heard from the transport
Okay.
report. Sounds like he got IV started at the outside hospital.
Yes, and his right wrist.
Great. And then he got a bolus, I'm told, during transfer as well.
720 mils.
Perfect. And then some Zofran.
Yeah, I think he's had some vomiting. I'm not sure when the last time was, though.
Okay. Well, why don't you take a look over him and do your assessment, and then we'll talk him over.
Okay. Howie, I'm just going to listen to your lungs, okay? Okay, he sounds pretty good. To me, it looks like he's pretty pale and dry. His cap refill's about a 4 or so.
Okay.
But I didn't see any rashes or anything like that on what I could see of him. He just seems to be pretty tired. Mom, do you know the last time he threw up?
He spit up a little bit, but only once since he's gotten here.
Okay.
All right. Well, Mom, they also did some labs at the outside hospital, which I'm looking over here. Looks like he had a sodium of 147, chloride of 110, glucose 85, potassium 4.8, CO2 of 12, and a creatinine of 1.2. Then he had a CBC that looked pretty good, hemoglobin of 12, white blood cell count 25, and the platelets at 81. So we'll be looking over these numbers and seeing if we need to do additional tests here.
Okay.
Can I get the last set of vitals that we got?
I just took his temp, it was 37.6.
Okay.
Heart rate's 121, sats are 97%, and he's still on room air. And his blood pressure is 91/55 with a mean of 67.
Great. Thanks so much for that.
You bet.
I'm going to step out and grab our attending doctor, and then we'll talk over the case with you and decide what we're going to do next, okay?
Okay, yeah, thank you so much.
Of course.
Hey guys, how's it
Dr.
going?
Hey man.
Hey.
Amy and I just got done looking over this
Hey.
kid, Howie, in here. 8-year-old kid coming in with some vomiting, some concerns for dehydration, a little bit of headache as well. We looked him over. He's got a little bit delayed cap refill. It looks a little dry, so we're thinking he definitely needs some fluids. He got a bolus en route and some Zofran. Seems to be looking a little bit better after that, but still having some retching and vomiting. I'm starting to think, it's probably a stomach virus, like a gastroenteritis type picture with the vomiting, but he did just travel to that Table Rock area, so I'm a little worried about maybe some exposures in the environment there. He also has a headache, so I'm thinking, maybe like meningitis is in the differential.
Okay.
But vitals look pretty good right now.
Why don't you tell me what his vitals were? Most recent?
Yeah, so the most recent one we got here was a temp at 37.6, heart rate 122, resps 24, and his pressure 90/54 with 97% on room air.
Sounds good. And what about any labs?
Yeah, so they did some labs at the outside place. You can see them. I got them pulled up right here. You can see the one thing I was a little concerned about is creatinine looks a little bumped. It's like 1.2, kind of speaking towards him being a little dry.
Sure.
And so there's the rest of the
Yep.
electrolytes right there.
And that bicarb.
Oh, yeah, you're right. Bicarb's only 12. Yeah, so a little acidosis going on.
Agreed. Okay.
And then on his CBC, I noticed that his, white count's a little high. It's 25. Hemoglobin looks okay. Platelets were 81. I don't know. They're a little low. But I wasn't too worried about that.
Okay. And
Okay.
you were going through your differential. Let's go through that.
Yeah, so I was thinking, high on my list, of course, is stomach virus, common things being common, but, with his travel exposure, worried about maybe like parasite and type infection, and then with the headache, I was thinking maybe something CNS, like meningitis, and so those are the different things I'm thinking about.
Yeah. So, meningitis, he's not really got altered mental status at this point.
That's
right?
true,
He doesn't have a
yeah.
fever.
Right.
And I didn't hear anything about neck stiffness or anything.
No, he doesn't seem to
So
have that.
probably lower down on the differential.
Sure.
And then you mentioned parasitic infections. I don't jump to those right away.
Okay.
Kids go all over the place without getting any, parasites and stuff. So I'm not too concerned about that.
That's a
Now,
good point.
what you said that was probably most likely is, it's viral infection.
Sure.
Viral gastroenteritis.
Yeah.
That's, I think, how we should treat it. You'll feel a lot better with, some fluids like you mentioned.
Yeah.
Something for nausea, a little bit of pain, a little bit of rest, We'll
Do you
take care
think
of
with
it.
this higher white count, it'd be beneficial to start antibiotics?
What do you think, Cooper?
I was thinking about that, but then I was thinking, he doesn't have a fever. He's pretty dry, which could be making all those numbers artificially look high.
Yep.
So I was going to hold off, but whatever you
Absolutely.
think.
No, I think at this point there's very little indication for antibiotics. It's a great idea.
Yeah, it's a good thought.
We'll keep it in
Yeah.
mind. But I think right now we'll do kind of the things that we outlined. So why don't we
Okay.
go over it so we can put the order?
Yeah, so I was thinking we'll throw in some regular vitals every 4 hours, some strict I's and O's.
Yep.
And then I was going to have Amy let me know if he doesn't make any urine in the next 4 hours so that we can keep an eye on his hydration status.
With him being pretty dry, would you like to do another 20 per kilo bolus?
Sounds reasonable.
That's a good
We're
idea.
talking about dehydration. I
Yeah,
think we
sure.
should
I'll throw
address
that in.
Yep.
Yep. And then I was going to start on some maintenance fluids. And then, I don't know, medication-wise, I wasn't really thinking there was much to give him.
No, I think he's got a headache, maybe some Tylenol.
Okay.
Right, and then for nausea.
Oh, yeah, we can schedule some
There you
Zofran.
go.
Yeah. And then, did you want any more labs, or?
Well, I think we should follow the white count. I think she brings up a good point. So I
Okay.
think we should get a CBC in the morning.
Okay.
Take a look at that white count, the platelets, and what have you. And then, we're giving him some fluid, and he's dehydrated. Hopefully, he picks up with his oral intake overnight. And so we should definitely get a chemistry, look at that creatinine again.
Good
look at
point.
that bicarbonate, right?
Okay, I'll put
That way
those in.
We're doing a thorough job of managing kind of all the issues that we've talked about.
That sounds good. I'll put those in for the morning.
Okay. Very good. Thanks, guys.
All right.
I'm going to go examine him right now.
All right,
Thank
thanks,
you.
Dr. H.
Hey Penny, I'm sorry to bother you. I know it's so late, but Howie just woke up and I noticed he's got this rash on his hands now. And when he woke up, he said his stomach hurts really bad.
Oh, yeah, he does. That was definitely not there at 8 o'clock. Oh, yeah, it's over here, too. Let's look at his chest. I don't see anywhere on his chest or abdomen. Let's look at his legs. Oh, he's got it on his ankles as well. Yeah, this is definitely new. I think I'm going to go call the resident and have him come take a look.
Okay, good.
Okay?
Yeah, I'm just
Okay.
really concerned.
Yeah, are you okay, bud? I know you're tired. Okay, I'll be right back.
Okay.
Hey, Penny, I got your page.
Thanks for coming, Dr. Cooper.
What's going on?
So he all of a sudden is developing this rash.
Oh, really?
And that is new, even for my 8 o'clock assessment. Mom just called me in, and he sounds like he's not he's feeling worse.
Okay.
So
He was talkative a little bit ago. We were really like chatting and stuff, and we were talking about basketball and then the camping trip.
Yeah.
He's just really tired, but he said his stomach hurts really bad, and he's still complaining of a headache.
Is and his stomach starting to hurt now? Because
Yeah.
he wasn't doing that before.
No, right before I called Penny, he was telling me how much his stomach hurt, and I asked him
Yeah.
if he felt like he was gonna throw up, and he just said no, it just hurt really bad.
I see.
And he said his head still hurt too, because I asked him if he wanted to watch TV, and he said no.
Have there been any changes in his vitals?
Well, his temp is now 38.5.
Oh, that's his first fever. I don't
Yeah.
think he's had one before.
And, no, he hasn't, and his heart rate is slightly more elevated.
Okay.
132. Respirators are still about 24. That's kind of what I've gotten all night.
Okay.
His blood pressure is, last one, I just took it again, 102/65, and his SATs are 96. So,
Okay. Has he been able to drink?
a little bit. He had a little bit at like 5 o'clock-ish, right, Mom? And that was about, I got 576 is what the Daners charted.
Okay.
And then he has voided too.
Okay.
Like right at 8 when I first came on, about 160.
I gotcha.
you know, so-
Okay. All right. Well, do you mind popping the light on? I'm going to take a look at this rash.
Yeah, let me get the light for you.
Let's take a look at him, okay, Mom?
Sure.
Hey, Hallie. He's going to look you over. Oh, his heart rate's pretty fast. He's breathing a little heavy, too. It's probably from the fever.
Yeah, and I didn't see the rash anywhere on his
Oh, I see
chest
that.
or abdomen, but it's definitely on both wrists.
Huh. And it
A little
doesn't,
bit on the forearm.
doesn't really blanch for me.
No.
Huh.
And Mom had said it wasn't itchy.
Okay.
Um,
Oh, yeah, on his
and then
legs,
on
too.
his, yeah, kind of his ankles there.
Yeah, I noticed his cap refill that was delayed earlier seems to have gone away. It's more
Yeah.
real quick refill
Yeah,
now.
and his
he feels,
pulses are a little more bounding
he
too.
feels warm, yeah. Let's step outside in the hall and talk about what to do next.
Okay.
So we're just gonna go meet outside and kind of think this over and see what interventions we need to do,
Okay,
okay? We'll come
all right.
talk some more once we have a plan.
Okay.
Hey Penny, thanks for calling me in to see this kid. I'm also worried about this new rash, fever, and worsening heart rate. The rash blanches, so I'm not super worried that this is, a problem with coagulation, but it does kind of make me, between that and the fever, raise my suspicion for a more serious infection.
Don't you think we should do some antibiotics?
Yeah, that probably, I'm going to check with Dr. H.
Okay,
I don't want to make that
okay.
decision without his input. I'm thinking that we should definitely do some workup for infection. So
Okay.
let's send another CBC, a Chem 14,
Okay.
blood and urine cultures, and a procalcitonin,
Okay.
just to kind of get some baseline and work them up for infection. And grab a mag and a phos too while we're at
Okay,
it.
sounds good.
Yeah, thank you.
His heart rate's a little bit high. Do you want like another bolus or?
Sure, I think that's a
Okay,
good idea.
okay,
Let's
I'll
do
do a
that. Let's
20
do
per
lactated ringers since we're
Okay.
worried about infection now.
Okay, I'll do a 20 per kilo bolus, antibiotics, and then that pain, that's a lot more than what he's had for me.
Sure,
so-
sure. Well, I was thinking we could give him some Toradol, but with his kidney function, maybe it's best to stay away from that.
Okay.
I don't really want to sedate him with opiates. Why don't we just try some Tylenol for now and see how
Okay.
it goes?
Sounds good. I'll do the Tylenol. So antibiotics, fluids, or you're gonna check on the antibiotics?
Yeah, I'll double check that.
Fluids and some Tylenol.
Sounds good. Thanks so
And
much.
labs. Okay.
Appreciate it.
Sounds good.
And let me
Call
know if
Dr.
any.
H and
Yeah,
let
let
me
me know
know.
if anything changes that worries
Okay,
you. Okay.
thank you so much.
Yep.
Hey, Penny.
Hey, how are you?
Good.
Hey, I was just coming in. I'd given that pain medicine about 20, 30 minutes ago.
Sure.
You guys' painful?
Oh my
Is that
gosh,
better?
he's being so silly. He thinks we're camping.
You think you're camping?
Yeah, he's just been saying like something about the tent and like something about that, and he just thinks we're camping. And I was like, that's not where we are, buddy.
Oh, okay. Well, this might be a little concerning, so I think I'm gonna call the doctor. Does he seem confused? You mean?
Yeah, he doesn't remember we were in the hospital, and so I just thought he like had a dream or something. But he thought we were camping, and he was talking about his dog.
Okay. I'm just gonna go give the resident a call and check on those antibiotics. They
Okay.
should be coming up. Too.
All right, thanks
okay,
so
I'll be
much.
right back.
Hey Penny, I got your page.
Hey, sorry.
No, you're okay. What's up?
Bugging you a lot tonight.
No big deal.
But poor little Howie, his temperature is a little bit higher.
Okay.
39.4 now.
All right.
And he seems to be a little confused.
Yeah, I thought he was having a dream, and he was talking about camping and talking about his dog, and I was
Uh-huh.
like, no, Howie, we're at the hospital. And he just doesn't seem to realize where we are.
I see. Okay. How are the rest of his vitals?
Well, a little bit more tachycardic.
Okay.
145, his respirators are 30, blood pressure 104 over 66.
Okay.
His sats are still fine, 94%.
I see.
His pain is maybe slightly better. I had come in to actually assess that. That's when
Yeah.
Mom had said that he was feeling a little silly.
So, have we gotten any of those labs back yet?
Not yet.
Okay. And then
No.
Dr. H did want to go ahead and do those antibiotics.
Okay,
Okay,
good,
so,
good.
so I'll put those in.
Okay.
But let me take a look at him real quick. Howie. Hey, buddy, are you with us?
Yeah,
Man,
he's
he really
not-
does seem
yeah,
confused.
He's not really responsive as much.
I'm a little worried about him, to be honest, Mom, okay?
Okay.
Sometimes confusion can be a sign of more serious things going on.
Okay.
I think we need to take him down and do some pictures of his head with a CAT scan and see
Okay.
what's going on, okay?
Okay.
I'm gonna call my attending and let him know what's going on, and we'll get moving downstairs, okay?
Do you think I should call my husband?
I think that's probably a good idea. Yeah.
Okay.
He's in good hands, Mom.
Okay.
We'll take good care of him.
Just let us know if you need anything, okay?
Okay,
All right.
thank you.
Okay, I'll be right back to get him loaded up to go to CT.
Okay.
Okay.
Thanks for coming, Dr. H.
Oh, I'm so glad you guys are here.
Yeah, I heard all the changes that have been happening, and man, things have really gotten worse really fast.
Yeah, his temperature is worse. Vitals are worse. We just got back from the CT.
Mom, why don't you have a seat? We're just going to
Okay.
talk things through real quick.
Okay.
We'll get a good plan going.
So we ordered those stat labs,
Okay.
got the antibiotics on board,
Good.
and got the scan. I haven't seen the results of the labs or the scan yet, but he continues to get more confused, faster heart rate.
Yeah, I see the sats are also lower there.
Yeah.
100%. And he's got this rash that's
New
getting
rash.
worse, right?
Yep.
So there's,
His blood pressure's 84 over 50 now.
you know what, I
Yeah.
think we're beyond the things that we can take care of on the floor. I think this would, I think I recognize, he needs to go to the PICU.
What does that mean?
So, sorry, I should explain. When he came in here, he was, he had the headache, he had the nausea, vomiting, but he was, making sense, talking to us. And when we assessed him, it looked like everything seemed in order, and he just needed some fluids and a little bit of rest, okay? But as you guys astutely picked up over the course of the night, things have been getting worse. So then he spiked a fever. And then when we kind of felt him out, we felt that his perfusion, how blood is traveling to the rest of his body, was changing. All put together, it sounds like there is an infection that we're not really treating fully and appropriately. And at the floor right here, we can only do so much.
Okay.
But my critical care colleagues are going to be able to give him more fluids, more medications, attend to him on a minute-to-minute basis, and really get to the bottom of this. And I think that's really where he needs to go right now.
Okay.
Okay? So he is getting sicker, Mom, but I think we have done all the right things right now, and I think moving him to a higher level of care is what's going to ultimately take care of it.
Okay.
Okay? So I know you're worried, but we'll talk to you about everything. We'll keep the lines of communication open, but let's get him to the PICU now, and then we can talk as things move forward.
Okay.
Okay? What do you guys think about that?
Sounds good, I'll go make the call.
Okay, sounds good. Let's
All
go,
right.
let's roll.
Okay, let's get him ready.
Okay.
Well, welcome everybody. Thanks for joining us in this sepsis case study series. We went through multiple different scenes with a potential patient, and there were multiple changes that happened to that child as time went on. And so we wanted to kind of go through and help point out some of the salient features that helped us understand kind of where this kid was on the sepsis continuum and where the kid was heading. So at this point, you've seen scenes 1 and scenes 2. Take a minute to think about what those salient features might be. What are the things from this that stick out and that need to be addressed?
And so, with sepsis, if you're waiting till the kid is in shock, super sick, you've kind of missed the boat. We all know when those kids are sick, that they're sick. We try to capture these kids earlier in the process, and research shows us when we do that and we start goal-directed therapy sooner, the kids have better outcomes. And so what we really want to hone in on today is recognizing sepsis earlier in the process. And there's a way to do that by looking over the kid from head to toe and understanding the signs and symptoms of sepsis.
As he mentioned, when we have done that head-to-toe assessment, if you look at this right after the second scene, the child was afebrile, though he was tachycardic, right? An 8-year-old with a heart rate of 122, that should start to set off some bells in your head. The respiratory rate seemed okay, blood pressure seemed okay, saturations were good. So he's really in a good place right now, and I wouldn't say he is septic because we haven't actually identified an infectious source. So let's go back and think about SIRS versus sepsis at this point, right? So SIRS is defined as having one of the 4 following signs with a fever. This includes tachycardia, which he had, tachypnea, which he did not, an elevated white count, okay, and or bandemia, or a low white count, okay? And in this case, with the physical exam, he simply had tachycardia, right? And then when you look at his labs, though, he did have a leukocytosis at 25, okay? We don't have a band count there, but he's got a couple of different signs right now to suffice the diagnosis of SIRS, okay? What are the couple of other things that we picked up on?
So the things that I like to look for when I'm doing a head-to-toe assessment for a child with, when I'm considering sepsis in the differential, is I like to think by organ system.
Mm-hmm.
So
Yeah.
the first thing I like to think about is the brain. So kids in shock, or kids in early sepsis have issues with perfusion of the brain. They can get confusion, they can get headaches, they can get irritability that can be masquerading as other things going on when really it's sepsis. As you make your way down, I like to think about the heart next. So tachycardia is a very common early sign for SIRS and sepsis. And then secondary to that tachycardia is your perfusion. And so you're looking at how your capillaries are refilling and your peripheral perfusion. And so early on in the course of sepsis, oftentimes you'll actually have warm, flash capillary refill and bounding pulses. And as it progresses, you can sometimes move into the more cool, cold, clamped down extremities. So that's an important features to look at. Next organ system I think about is the lungs. So tachypnea, hypoxemia, those types of things can be signs in sepsis as well, as the body kind of runs its internal marathon fighting off this infection. And then in your gut, when the body is in kind of early stages of shock, one of the first things it does is shut off circulation to the gut. And so that can lead to vomiting and upset stomach. And so those are things to look for as early signs of sepsis as well, as the body tries to preserve blood flow to the most important organs, heart, brain, and kidneys. Speaking of kidneys, that would be the next organ system I worry about. And so things to look for on that would be decreased urine output, increased creatinine on your laboratory values, as indicators that your kidneys are not doing well. And then, I skipped over the liver. Can't forget the liver. Signs of the liver being affected in sepsis are issues with coagulation, low platelets, and bleeding disorder. So those are all things to be thinking about as you do your head-to-toe assessment in a patient with possible sepsis.
And so, as Zep pointed out, the few things that in our assessment that jumped out at us when you look at his labs, his creatinine was elevated, right? We already know from history that his urine output was low. He also had a high white count, which I mentioned as part of the SIRS criteria, but he did have low platelets. That's something that was kind of glossed over, but kind of purposefully done. You guys need to think about all these labs that are coming in to think whether these fit into a diagnosis of early sepsis or not, because really, as we mentioned, that's where we want to act. Thankfully, he didn't have any altered mental status. He was tired, but he was still talking to us, and he was still interactive. And he didn't have any signs of hypoxemia, right? His saturations were fine, he was on room air. And his respirations were also at a normal rate, and his blood pressure was also fine, right? So all put together, he sufficed a diagnosis of SIRS at this point with his white count as well as his tachycardia, and that's about it. We didn't have any real evidence that he had an infection, which if he did, he would then be in sepsis. Suffice it to say that the other signs, like the creatinine and then the platelets, should make you start thinking, are we in sepsis at this point or not? And that's just a question to discuss with the team. That's what the important message we're trying to give over here. It's all about the discussion and bringing people in so that you have that differential in your mindset, so that if things start to get worse or follow a different path, then you're ready to pivot from whatever the other diagnosis is that you were trying to take care of. In our case, we were thinking, this is just a viral infection,
course,
gastroenteritis, right? However, if we had kept sepsis kind of in the back of our mind, then some of the other interventions that were coming later could have been done potentially earlier.
And you know, like I am fond of saying, sepsis care, 90% of it's recognition. Once we know that sepsis is what's going on, then we know how to treat it and we know what to do. And like I was saying, the data shows the earlier you do those interventions, the better the kids do. And unfortunately, there's no test for sepsis yes, sepsis no that we can do. It's a constellation of findings, and they can be subtle, and they can mimic other disease processes that we see in the kids that we see every day. And so it's really important just to keep it in the back of your head and be thinking about it at all times.
So then as we progressed through the rest, to the next few scenes, we noticed that things were actually getting worse, right? So when we had finished the fifth scene, wherein the child now had a respiratory rate in the 30s, his cap refill was flash, his pulses were strong and bounding, okay? Things are now changing. He also had a fever at that point, at 38.5. So now he definitely has all 4 criteria for SIRS, right? He has a fever, he's tachycardic, he's tachypneic. We have already discussed that he had leukocytosis, okay? On top of that, we do have a potential source of infection, even though we haven't diagnosed an infection, right? He had gone to the state park, and what we were kind of taking you down the road here was he has a tick-borne illness, okay? And because things have now progressed into differences in perfusion, we are in definite state of sepsis, and we've got to find out if he's now going to progress towards severe sepsis. Now, with that change can be subtle, but the definition of severe sepsis, okay, is when you have signs of sepsis, you have given, and you're finding signs of tissue hypoperfusion. Okay, the same things that Zeb talked about, altered mental status, and urine output are the 2 things that we go to the quickest, but changes in your creatinine, changes in your LFTs, DIC, all those things can lead you into a severe sepsis pathway. So severe sepsis is defined as having signs of sepsis, okay, and then having signs of tissue hypoperfusion. And the 2 that we go to readily that are available to us when we're first assessing a patient is the mental status as well as the urine output. Okay, so when a child has altered mental status, okay, or depressed urine output, then the child has impaired perfusion. Now, the other things in the physical exam in this case that suggested the child was in severe sepsis was, if you think about it, his cap refill went from, delayed when he was dehydrated to flash, okay? And his pulses, as the resident noted, were bounding, okay? Those suggest that the child is suffering from a problem with perfusion. And so the child has now gone into severe sepsis, albeit early, without signs of altered mental status. Again, it's a good place to catch this child, okay? You might be fooled with the urine output because he came in dehydrated with low urine output. But in this scene, he had only voided 160 mLs, despite getting 2 20 per kilo boluses. That is also a sign of impaired perfusion. The kidneys are not being perfused well enough, and hence they're not producing the necessary urine that you would expect if they were perfusing well. So this child definitely at this point is in severe sepsis.
Agreed. Yeah, so laboratory adjuncts can be helpful in the diagnosis and management of sepsis. Unfortunately, like I was mentioning earlier, there is no sepsis test that tells you if it is or is not. It's a constellation of symptoms. But some of the labs can be really helpful in making those determinations and also risk stratifying your patients. And so the CBC with the white count can be helpful. Especially with the differential, looking at your band counts and immature neutrophils. The one thing to always remember, though, in sepsis is that the white count is not as reliable as we sometimes think. Sometimes people disregard sepsis in the differential when there is an elevated white count, when actually the white count isn't as sensitive as a lot of us are taught. And also, one other thing to think about that's even more concerning to me in the emergency department is low white counts. So leukopenia is actually a sign of late-stage sepsis, especially in neonates. And so you should always be thinking about your white count in context of their patient's presentation and not rely on it. Other things we like to send are the lactic acid. Lactic acid is a good indication of your end organ perfusion, and so if that number is starting to creep into higher levels, there are good research papers out there that show those children are more likely to need the ICU, more likely to need vasoactive agents, and more likely to be intubated and have long ICU stays. So that's why we like to send the lactic acid for those reasons. My personal favorite is the procalcitonin. It's a relatively new biomarker that has better sensitivity and specificity for sepsis and serious bacterial infections than most any of the other markers that we use, including other inflammatory markers like CRP. We built it into our standard order sets for children here at Children's. And so you'll see that being ordered routinely, and do try to familiarize yourself with the normal ranges on it because it is a valuable marker.
Perfect. And the resident astutely ordered all of those tests. But while we're waiting for the tests to come back, we always say we need to act. Once we have diagnosed sepsis or severe sepsis, we need to manage the child, right? And so there are two very important initial actions that were taken that I think were very important in this case, right? So the nurse asked about giving antibiotics, right, to the resident, and they decided we need to give another bolus. So as soon as you have diagnosed severe sepsis, you should be on kind of the algorithm of treating them right away with antimicrobial therapy as well as volume resuscitation so that you can address the perfusion issues that you're seeing, and so you can see how the child responds. Because if the child does not respond to volume resuscitation, then they have gone into septic shock, okay? And that's where the scene went. Because now the child, despite getting multiple boluses, had altered mental status. The patient was confused, okay? And the resident kind of came in, the nurse came in, everybody was assessing the patient, which is all the right and appropriate things to do. And at that point, the resident thought this confusion needs to be addressed with a stat head CT, which isn't necessarily a wrong order, but just consider what could happen if the child actually did go into septic shock and devolved clinically down in CT. So what we like to say in the critical care unit is when a child is unstable, you do not send them for diagnostic tests off of a unit. You manage them in the unit, stabilize them, and then get the data. Okay? So we did this on purpose. The child went down for a CT, wherein the child should probably have either had an RRT called or been transferred at the point where the child got confused. Because all the initial steps had already been appropriately deployed in the acute care setting. And hereafter, your job is going to be not just to have the first few steps placed in, but to make sure that the child went to the right location for the rest of the management.
And if I might elaborate a little bit on the antibiotic portion real quick, it's critically important to get antibiotics on as soon as possible once the recognition of sepsis is done. Research shows us that for every hour of delayed antibiotic administration in children with severe sepsis, that they have a 9-fold increased likelihood of death. And so prioritizing those antibiotics and getting them in the kid as soon as possible is critically important.
Yep.
I don't stress that.
One final note, Surviving Sepsis campaign gives us some very nice guidelines that I would like all of you to refer to. And one of the main things it talks about relating to antibiotics is that those hospitals that had a sepsis bundle, okay, that had certain things in that bundle had much better survival than hospitals that didn't. The difficulty is which part of the bundle is important. In our opinion, it's not which part is important. It's the fact that the bundle is deployed as is and deployed early. Okay. The last scene here was the child being rolled to the PICU, but the child was already hypotensive. In our opinion, that is too late to be sending the child out because that child can potentially code on the way to the PICU. So if there's one takeaway that you take out of here is remember the salient features of sepsis, okay, and aim to make the diagnosis earlier and bring people to the bedside so you can discuss where and how the child should be managed.
And we stressed this earlier, but I want to stress one more time that hypotension is a very, very late finding in pediatric sepsis. And our adult colleagues routinely will see hypotension earlier on in the course, but children are very resilient to these infections, and they don't get hypotensive until they're really on their last leg. And so waiting for that to cause you to escalate care in a kid is too late. And so that's why we have to be looking for these more subtle features earlier on.
Perfect. Thank you so much for your time, and please feel free to contact anyone on the team for any questions you guys may have. Best of luck.